Hello and welcome. Today we're diving deep into a fascinating yet complex area of kidney health. Type 4 renal tubular acidosis, also known as hyperkalemic RTA, will unravel what it is, what causes it, how it affects the body, and what can be done about it. So, let's get started. Type 4 RTA isn't a single condition, but rather a syndrome arising from several underlying problems. The most common culprit is diabetic neck nephropathy, the kidney damage that can occur from long-standing diabetes. However, it can also stem from tubular interstitial diseases, such as chronic kidney disease, obstructive uropathy, a blockage of the urinary tract, and certain medications like ACE inhibitors, ARBs, NSAIDs, and potassium-sparing diuretics. In rare instances, adrenal insufficiency, which reduces aldosterone production, can also lead to type 4 RTA. Finally, inherited conditions such as pseudohypoaldosteronism can cause a similar clinical picture. To understand type 4 RTA, let's break down the pathophysiology. It essentially boils down to impaired kidneys' ability to excrete acid and potassium. Aldosterone, a crucial hormone produced by the adrenal glands, plays a pivotal role in regulating sodium and potassium levels in the distal tubules of the kidneys. Aldosterone stimulates sodium reabsorption and potassium secretion. In type 4 RTA, either aldosterone levels are low as in adrenal insufficiency, or the kidney tubules are resistant to its effects, as in diabetic nephropathy. This leads to reduced sodium reabsorption and, most importantly, reduced potassium excretion, causing hyperkalemia. Furthermore, the impaired ability to excrete hydrogen ions results in metabolic acidosis. The reduction of ammonia production further aggravates the acidosis. Type 4 RTA is relatively common, especially among individuals with diabetes and chronic kidney disease. Its prevalence increases with age and the duration of these underlying conditions. Because diabetes is a major risk factor, the global rise in diabetes incidence is likely contributing to an increase in cases of type 4 RTA. The signs and symptoms of type 4 RTA can be subtle initially, often masked by the underlying conditions. Common symptoms include fatigue, weakness, and generalized malaise. Patients might experience muscle cramps or palpitations due to hyperkalemia. As the acidosis worsens, individuals may develop nausea, vomiting, and shortness of breath, or even cardiac arrhythmias. The severity of symptoms depends on the degree of hyperkalemia and acidosis and how quickly they develop. Diagnosis of type 4 RTA involves a combination of blood and urine tests. The key findings are hyperkalemia, elevated potassium levels in the blood, and metabolic acidosis, low blood H and bicarbonate levels. We also need to determine the urinary anion gap to assess urinary ammonium excretion. It is typically positive in type 4 RTA. A fractional excretion of sodium may also be assessed. Further investigations are necessary to identify the underlying cause, such as measuring aldosterone levels, performing kidney imaging, ultrasound or CT scan, or assessing kidney function with glomerular filtration rate (GFR) measurements. The clinical context, including patient's history of diabetes, medication use, and presence of chronic kidney disease, is essential for accurate diagnosis. While not classified into subtypes like other RTAs, it's useful to distinguish between type 4 RT due to aldosterone deficiency and that due to aldosterone resistance. Aldosterone deficiency can be caused by adrenal insufficiency or certain medications. Aldosterone resistance, on the other hand, typically results from diabetic nephropathy or tubular interstitial diseases. Identifying which of these mechanisms is at play guides the treatment approach. The primary goals of treatment are to correct the hyperkalemia and acidosis and to manage the underlying cause. Dietary potassium restriction is often the first step. Medications like sodium bicarbonate or sodium citrate can help correct the acidosis. Loop diuretics, such as furosemide, can promote potassium excretion in the urine, but should be used cautiously to avoid dehydration. In cases of aldosterone deficiency, mineralocorticoid replacement therapy, such as fludrocortisone, may be necessary. Importantly, managing the underlying condition, such as diabetes or chronic kidney disease, is crucial for long-term control of type 4 RTA. Preventing type 4 RTA largely involves managing the underlying risk factors. For individuals with diabetes, strict blood sugar control is paramount. Regular monitoring of kidney function, including potassium levels, is also essential. Avoiding medications that can exacerbate hyperkalemia, such as NSAIDs and potassium-sparing diuretics, is important, especially in individuals with kidney disease. In cases of obstructive uropathy, prompt treatment to relieve the obstruction can prevent further kidney damage. The prognosis for type 4 RTA depends largely on the underlying cause and the severity of kidney damage. With appropriate treatment and management, the symptoms can be effectively controlled and further kidney damage can be minimized. However, if left untreated, severe hyperkalemia can lead to life-threatening cardiac arrhythmias. Recent research is focusing on developing more targeted therapies to improve potassium excretion and correct acidosis in individuals with type 4RTA, particularly those with diabetic nephropathy. New potassium binders and selective aldosterone receptor antagonists are being explored as potential treatment options. Furthermore, studies are investigating the role of dietary interventions and lifestyle modifications in managing type 4RTA. Thank you for joining us on this journey to understand type 4 renal tubular acidosis.